and you're absolutely right. Whenever you, okay, because let's just say that you go 6 degrees. So that means here's at 0, and we do our next one at 6 degrees. Okay, what you wind up getting is what they call a spoke artifact. Because, does anyone know how spec images are reconstructed? You're going to get an image that looks like this. You know, here's the object that you're taking a picture of here. But for every gap, you're going to have what they call a spoke artifact that is a problem. Okay? So that's why 6 degrees is the minimum number that you can get away with without creating this spoke artifact. Okay, there's nothing you can do for it. But the method that I just mentioned, we have a thing called back projection. We have back projection and we have filtered back projection. So what's the difference? Which one do we normally use? It's awfully quiet out there. How come it's so quiet? Okay, let's take a look at how a gamma camera works, okay? So here's your patient. Here's the gamma camera going around the patient. And this is true of pretty much all of our imaging technology. MRI's kind of changed them. MRI kind of does the same. It's a direct, what they call Fourier transform. That's why they get nicer pictures. But CT and SPECT still typically uses back projection. So let's say that there's a source of radiation here, and it has 100 counts that it's producing. Okay, if we were to look at this thing on a computer, and when you're looking at this thing on a computer, one of the things you need to be aware of is your gamma camera isn't just taking one slice. Okay? This is a picture from a cardiac book that we use. Okay, when you do an image of the heart, you're actually taking about 14 slices. Okay? So beginning at the tip, this is your, what view is that, by the way? Okay, this is your short axis view. Okay, your short axis view is the basis for all of your other views. Okay? What you're looking at is each one of these is so many millimeters when you did the original rotation around the patient. And then when we have that information, we can then reorient it. Because remember, we told you that these things here are nothing but lines of information, lines of numbers. Okay? It's a signal. And I can take that signal and I can reorient it any way I want. Okay? And this is true of all of our imaging. All of the axial views are used to reconstruct the other ones. So in this case here, whenever you're looking at a cardiac study, especially, how many of you look at it like this? You guys have a polar view? Yeah. And when we get into the cardiac, you'll see this again, but you should know which blood vessels supply each of these areas. Which blood vessel supplies this area of the heart? What? Huh?
The 80? Is that the anterior?
This is the left anterior descending. What part of the heart is this? Huh?
Left ventricle.
Well, the whole thing is the left ventricle, but okay, this is the lateral wall, this is the inferior wall, this is the superior or anterior wall, and this is the septum. Okay, so yeah, you're right. This whole thing is the left ventricle. I mean, the left ventricle here. Okay, but you need to know which artery primarily provides each one of those areas. So this is the left anterior descending. What's this one over here? When you guys are sitting at the desk, you should be looking at what is being displayed up there, right? You know, you're there not to only be a worker bee, but you're there to learn. So you need to find out what are all these things that you're supposed to be knowing about a heart scan. I think a doctor might come by later and say, what's going on here? Okay, this is the circumflex. And then which one provides the inferior portion of the heart? Huh?
Right coronary artery?
Right coronary artery, very good. So the right coronary artery, circumflex, and LAD. Okay? And probably by now you guys have learned how to interpret these, right? So is this, when we have, looks like there's no perfusion defects on the, is that the rest or the stress?
Stress.
Okay, so there's no perfusion on the stress, or no defects, and there's no defects on the rest, so what do we have here? That's a normal study, that's what you would expect to have. Okay, what about this one here? Defect on the stress, fills in on the rest, so what do you have?
Ischemic tissue.
Okay, it's myocardial ischemia. Okay, when this thing fills in, it means that when the patient rests, they're probably getting angina when they're at this phase, but when they rest, the muscle gets perfused and it's back to normal. So this is myocardial ischemia. Okay, but like I said, we're going to be spending more time on the cardiac system here, but I wanted you to kind of get an idea of this is what you're looking at. So basically when you do a SPECT study, you take the organ and divide it into a certain number of slices, and then those slices are reoriented for the sagittal and the coronal slices. When you're looking at a bullseye, you're basically taking this thing and flipping it to where you're looking straight down the wall of the heart. Okay? So, we'll get into that a little bit later. But we want to talk about back projection here for a minute, because some of the different computer stuff that we're going to be discussing, so when the detector is over the patient and it detects 100 counts, okay, it's going to create a signal that looks something like this. Okay? There's no activity. Remember what we call this line that I'm drawing up here? What would we call that line?
Fourier transform.
Okay, it's a Fourier transform. It's also a profile slice. Okay? So basically what it's telling me is the detector located a source of radiation somewhere in this row. That's exactly what it's looking for. Okay, now the problem is, where in that row did it occur? Okay? So by looking at different slices here, okay, so we know that there's probably going to be maybe 50 counts detected this way. Okay, we know that somewhere along here there's 50 counts, and then we go to the side over here, and then we get another 100 over here. Okay? So, whenever the computer detects something, it's going to send that number back down that row of pixels. So in this case here, I'm going to put 100, 100, 100, 100, and 100. Okay, here I'm going to put 100, 100, 100, 100, and 100. Same thing here, 50, 50, 50, 50, 50. Now in this case here, you notice that when I'm going 100 across like that, that puts 100 here and a 50 here in that one box. Okay, so now the computer has what we call, this is the back projection part that we're talking about. I've detected something here, I need to know its location. So by sending a signal back down there, what they call a ray path. You guys remember your geometry? What's a ray path? without looking it up on the internet. Okay, Mr. Singh, in your geometry class, what is a ray path?
I don't remember. I don't think I have heard that before. I don't know.
Well, you remember what a line is, right? Remember a line is something that's infinite? Basically has no beginning and no ending point. Okay, a ray has a point where it starts and then it continues out from there. Okay? You guys use this all the time without realizing it in the reconstruction of your images. When we're doing what they call edge detection, or if you're doing them, has anyone done a MUGA study? Okay, if you do a MUGA study, this is how the computer is able to tell where the edges of the heart are by doing what they call a ray path. But we'll talk about that in a second. Okay, so with back projection then, we have a situation where all of these projections intersect at the source of my radiation here. Now, if I just left the picture like that, it would look something like this. Okay, I'd have, like, here's my pixel that has all of the intersection points there, but then I would have all of these lines coming off of it from all 64 projections that we made. And this is what they call a star. Sometimes they call it a spoke artifact also. But you got to be careful if you call it a spoke artifact that they don't confuse it with having too many degrees between your projections. Okay? So this is what a back projection image would look like if we didn't do something about it. And I think on... What's that?
The raw data and the gated and ungated.
Well, this is just raw data. What's the purpose of gating?
To reject certain beats.
To reject certain beats. Ashley, what is the purpose of gating?
You can watch the heartbeat on processed images.
You can watch the heartbeat on processed images. Andy, what's your interpretation of why we gate studies?
I don't know. I never asked.
You never asked?
I never asked.
How come?
Never been kidding
Just say, here, hook this up.
you.
Well, I mean, okay, honestly, we don't care. We're not monitoring the heart for any, what we're basically trying to do is we want the heart images to be taken at certain phases of the heart cycle. Okay? Because if I have my hand here and it's going like this, what's the problem? Motion artifacts, right. So, by doing gated acquisition, okay, here's my end diastole and here's my end systole. If I only take pictures of those two phases, I'm eliminating all this other motion in between. Okay? So, in the old days, before we started gating our acquisition, we basically had a moving picture. So, you weren't able to measure the thickness of the muscle in the ventricles, you weren't able to really get a good idea of, wall motion until we were able to just take a picture of end diastole and end systole. Because then now I can say, oh, well, this is how much motion the heart is actually producing during those two cycles. So gated acquisition is designed to improve the resolution of our studies. Okay? But, then like you said, when you have arrhythmias and things like that, it's designed to reject those beats that fall out of that rhythm. But going back to our story over here, I was thinking that there's, on page 57, okay, this kind of gives you an example of what they're talking about. Okay, we know that there's something along that position there, but as again, if you imagine there's 64 projections taken, 32 if we're looking at the heart. So the problem is if we don't eliminate that, then we're not going to get a very good picture, are we? Okay, this is what it's going to look like. Okay, this is on page 58. So this is the star artifact that they talk about that's primarily only associated with, is that better? So mainly associated with back projection. Okay. In order to eliminate that, we apply a filter. Okay, it's called a convolution, or it's a convolution filter, and basically make it as simple as possible. If I subtract, after my image is complete, okay, what's going to be the number in this pixel here?
250.
250, right? What if I told the computer to subtract 100 from every pixel on the image? Okay, basically this would be minus 50, this would be 0, but this would still have 150 in it, wouldn't it? Okay? And that's basically what back projection is. If I kind of get an average of what all of the numbers are going from all 64 different directions, and I subtract that number, we actually use a filter called a ramp filter. Okay, and on page 58, this is what we use to eliminate that star artifact. Okay, it's a filter that on the edge of the image, there's not really that many counts, but this thing removes them, and it keeps on removing them at higher numbers until it gets to the object. Okay, so and this cutoff frequency down here, have any of you ever seen that when you're doing your studies? It's like a Butterworth with a 0.25 cutoff and or 0.15. What does that mean? Nobody?
Well, the other number to the right of it is to like adjust the noise, right? To smooth it out or make it more crisp.
Yeah, the order tells you, in other words, if you have a, let's say that we have an image here. Okay, we know that on an image there's going to be all different numbers in each one of these pixels, right? Okay, so let's just say that, okay, this is an image, it has all these different numbers in here, and we're going to select a cutoff of 0.25. The computer looks at your matrix, finds the pixel that has the highest number of counts, so it's going to take 125 and multiply it by 0.25. Okay. How much is that? Roughly 100, isn't it? Okay. So basically, with a so we're going to be subtracting any pixel that has 100 counts or less is going to be removed from our grid. So basically, now let's see. So this one would be allowed to stay. This would be stay. This one. Okay, this one would be removed, this one would be removed, this one would be removed, this one would be removed. So anything less than 100 counts is going to be taken off the play. Okay? So now you're left with then just an image that has, 4 pixels or 5 pixels in it. Does that make sense? So as the cutoff goes up, you're removing more information from your image. Does that make sense?
125 times 0.25 is 31.25.
Oh, 31? Okay, so 125 minus 31. Okay, so 94. Yeah, so I've just kind of rounded it off there. Okay, so this would be the actual number here. Anything 94 or less would be removed. Okay, I was just guessing it would be somewhere around 25 or something like that. Okay? And as this number goes up, if I went up to a cutoff of 0.50, okay, that means everything, okay, so 125 times 0.5 is what, 60 something? Basically what's going to happen is every pixel that has half the number of counts of this or less is going to be removed off of your grid. Okay? So
So it finds the highest pixel.
it finds the highest pixel, and then whatever 25% is of that, it allows, any pixel that's 25% or less than that is going to be removed from the image. And on page 59, it kind of gives you an idea of what happens. Okay, this is what they call a high-pass filter. And, what's that?
Can't see it. It's blurry. Is that the way it's supposed to look?
I don't think it's supposed to look blurry. I don't know if there's a, let me see if I can focus that a little bit better. Is that better? Let me just, zoom out maybe. Yeah, I think it's. Okay, when we use a high-pass filter, that makes the image have sharper edges. Okay? And so typically what we do, when we do the cutoff, okay, the cutoff gets rid of the background. Okay, just makes your object stand out more clearly. And then what we do is we apply a high-pass filter to make the edges sharper, and then we smooth it with what we call a low-pass filter. Okay, so you notice that the edges look a little bit smoother now, they're not as sharp and jagged. So basically we use this to eliminate noise in the image, and we use the high-pass filter to sharpen the image, and sometimes you'll use a combination of both of these. Okay? In our repertoire of filters that we have available, some of the ones that you're going to hear about are the Hamming and the Butterworth filters. Have you seen those? You guys really need to kind of get into your computers, and when you do an acquisition and processing, you need to see what it is that you're actually doing to the picture. Because some people, as I said, they just sort of automatically, push the button and that's all they care about without understanding why they're pushing the button. And you don't want to be in that position. If you have a doctor that says, hey, I don't want this image, looking so smooth, well, then you could increase the filter cutoff and make it look sharpen the images. Basically, the way that this works, and this is also something that we use for edge detection. Let me just do this here for a minute. The first thing that we had talked about with removing certain numbers, okay, that's going to be your high-pass filter. That's going to get rid of the low-frequency objects. But so the high-pass removes low-frequency. And this would be things like your background. Okay, so basically low numbers will be removed from your image, and that will sharpen it. But again, when you have all of these numbers here, like, let's say we have 100 here, and 90 here, and 110 here, and we have these numbers like this, then you get an image that looks like that when we draw a profile slice through it. Okay, and this number, or these images, would be grainy because you have lots of gaps between pixels. So there's a lot of information that's missing. So to make it not look so bad and make it look a little bit better like this, okay, the low pass filter does a process called smoothing. There's actually a very sophisticated formula that we use to talk about this. But basically what it does is, we'll look at, well, let me go back here for just a minute. Okay, usually the smoothing is what they call either a 9-point, 5-point, or 3-point. If this is the number that we want to change down here, so let's say that we have a number in here of 100, then what your computer is going to do, it's going to look at the number of counts surrounding this thing. So a 9-point smooth would look at these surrounding 9 pixels, and again, I can't remember the formula off the top of my head, but it's 1/36, and then this is pixel number 1, 2, 3, 4, 5, 6, 7, 8, 9. So 9-point smooth is going to take 1/36 of the numbers, and basically it looks at it as 1 plus 3 plus 7 plus 9, and then that's going to be also, then that's going to be added to, I think it's 2 plus 4 plus 6 and plus 8. So in other words, the reason why they selected 1/36, can anyone tell me why that 1/36 would be a number that would be important when we're looking at all these 9 different?
10% of 360.
Well, it's 10% of 360, but the reason why they chose 1/36 is because they're looking at all of the possible combinations that you can add these things together. So if you looked at it diagonally, vertically, horizontally, any possible way you can, there's 36 combinations that you can use. Okay? So that's where the 1/36 came from. And then you notice that they've selected certain pixels, so like 1, 3, 7, and 9. Okay, and then they look at 2, 4, 6, 8. Okay, so by adding all these things up and multiplying them and dividing them and things like that, we get a new value for this pixel in the middle. And your computer does that for each and every one of these pixels. That's a lot of calculations, would you say, especially if you've got 4,096 pixels. And if you remember, we typically use a matrix of 64 by 64 when we do spec imaging. Everyone remember why we use 64 by 64 for spec imaging? Mr. Braid?
Not quite.
Mr. Viette?
Make more pixels.
Well, let's say you're doing a cardiac image, okay, and you have a choice of, Well, we got 64 by 64. We've got 128 by 128. We've got 256 by 256. So why do we select, well, what would be the advantages or disadvantages of using each one of these? What would be the advantage of going from 64 by 64 to 128 by 128?
Higher detail.
Okay, better resolution, right? Better picture. Okay, so as the matrix number goes up, the quality of the image improves, or it's not, it's not as pixely. But, so if that's the case, then why do I choose 64 by 64 for most of the spec images?
If you have a lot of images and any more information than that, it would like overload the computer with, a ton of memory.
Yeah, that would be a possibility. But remember now, memory is cheap. So, and at the end of the day, you're supposed to archive all of the images, or at least on a weekly basis, get all of those images off of your hard drive to make way for the new images, right? That isn't the reason why. I'll put Cynthia on the spot next, because she looks like she's dying to answer a question. Or maybe just dying, I'm not sure.
Just dying.
Do you remember a long time ago, I'll help Cynthia out here a bit. We talked about the number of counts per pixel. Do I get more counts per pixel in a 64 by 64, or do I get more counts per pixel in a 128 by 128?
Because there's a depth, there's higher depth in the 64 by 64.
Well, no, I can have the same depth for all of these. I can have 64 by 64 by 16 or by 8. Or I can have 128 by 128 by 16 or 8. And remember, what were these numbers over here for? Okay, that's the depth. And what do they tell you?
How many photons hit that pixel? So if one photon hit it, that would be 1, and then how many counts it could collect in a sense.
Okay, basically, yeah, this tells you the number of counts that you can collect. That's the maximum number of counts that you can collect in that pixel. This is also your color scale. Okay? So when you go to, image, or want to get the density and the contrast of your image, that's what you're playing with here. Okay? But going back over here, okay, if we had 30,000 counts, and I divide it by 4,096, because that's what 64 by 64 is equal to, how many counts would I have in each pixel?
.3.
7.3 counts per pixel? Okay, and if I did the same 30,000 counts, and I put it into 128 by 128, which I think is 16,384, how many counts per pixel is that?
Less counts, so the image quality is reduced, right?
Yeah. That's one problem here. Can you imagine looking at an image that has 1 count per pixel, or less than 1 count per pixel? Yeah, let's be generous. Let's give it 2 counts per pixel. Okay, what about the percent error? Remember we have this thing called statistical error, all based on counts? The gods of statistics said that you have to have at least 10,000 counts to have a 5% error. What do you think the error is on this? How would I calculate the percent error? Who's my math person here that loves math? Mr. Singh, you love math. How do we calculate the percent error due to statistics and the number of counts?
Percent error is the original counts divided by the original.
No.
The actual,
Depends what confidence interval you want, right?
Depends what confidence interval I want, but basically it's the square root of the number divided by the number. Okay? So in this case here, the square root of 7.3 is about 2 something, right? So 2.7 divided by 7.3, what's the percent error?
37%.
Okay, 37% error. Okay? If I go to this one down here, the square root of 2 divided by 2, pretty high error, isn't it? Over 50%. So as you get less counts per pixel, you have a higher statistical error, which we don't want. And when I'm doing a cardiac study, in order to make sure I get an adequate number of counts, I use a smaller matrix. I use a 64 by 64 matrix, so I don't have a problem with statistical error and with a real grainy image. If you have a lot of counts coming from the object that you're doing SPECT on, you can get away with doing 128 by 128. If you're doing a bone SPECT and there's a lot of counts from the bone, hey, knock yourself out. But when you're doing, I mean, how many seconds are you actually taking information on that heart?
25, 50.
Yeah, 25, maybe 30 seconds at the most. Okay, is that a lot of counts? Figure 10,000, 20,000 counts per second times 30 seconds that you're acquiring the study, and then it moves on to the next one. That's not a lot of counts. Yeah.
Going back to that, if we did like a bone scan on the pelvis and we did 64 versus 128, would we still get a better image with the 64 by 64, even though there were a lot of counts? Like you said, if there were a lot of counts, we'd use the higher up matrix.
Actually, I mean, if you're getting a lot of counts, then it would be better to use this. You know, like I said, it's all numbers. Unfortunately, you guys are coming into nuclear medicine where year after year after year, it was sort of taught by word of mouth. And this is what kind of scares me, because people are using protocols that are on their computer for studies that we may not even do anymore. What I mean by that is when we, you know, there's people that are using thallium protocols for sestamibis studies. But how do you know? Could you look at your computer and say, oh, this one is for sestamibia and this one is for thallium? Could you honestly do that? Could you go over and take an imaging center and you're the chief tech now because everybody quit and you're the boss, and the doctor says, hey, you know, these images look a little bit funny to me, can you help me out here? And all you do is you see, oh, here's a heart. Okay, well, you got a heart thing. You push that button and it's going to process whatever you did. You did a rest, you did the stress first and then you did a rest. Or you did the stress first, or rest first and then you did a stress. Okay, and that's another thing you guys got to be real careful of, because when you look at those protocols, you can do them either way. You can do the stress first and then do the rest. Some people do that because if the stress is normal, there's no need to do the rest. If the patient came in and because they were having chest pain, well, obviously you're not going to put that person on a treadmill, so you may do the rest first and then do the stress. Right? Would it make a difference which way you process them? Yeah. If you do the stress first and then do the rest, if you process it on the computer's going to handle both of those images differently. Some places do a dual isotope study. They'll do thallium and they'll do sestamibia. That's another big difference. The thallium and sestamibia have different biodistributions. Cynthia's nodding her head yes. Mr. Viat's hoping I won't ask him. Mr. Singh, does thallium and sestamibia have different pharmacologic actions?
Sure.
the That's what I do then.
Sesame goes to the parathyroids too, thallium.
Well, thallium goes to the parathyroids too, yeah. But how does sesame get into the heart muscle compared to how thallium gets in there?
Fatty acid.
Okay, sesame is a fatty acid. Your heart metabolizes fatty acid, so it takes it in. Also, it goes to the liver and the gallbladder, right? Okay. What about thallium? How does it get in?
The myelin channels, I don't know.
Okay, well, thallium is a potassium analog. How is potassium utilized by muscle? Okay, remember that, I'll put Ashley on the spot here. Okay, Ashley, if I inject 201 thallium, what is it similar to? What is it analogous to, or what's its analog? Okay, potassium, very good. Okay, so this thing is going to follow potassium distribution in your body, which means every time you have a muscle that contracts, the sodium goes into the muscle and the potassium goes out of the muscle, and anytime you have a movement of charged particles, that creates an electrical impulse which makes the muscle contract. But after the contraction, now you have a muscle that's full of sodium and all your potassium is out in the bloodstream. So the muscle has to pump it out. That's your sodium pump. So we pump it out, we replace it with the sodium, and then the muscle is ready for another contraction. Okay? But this stuff is going to stay in circulation. So it's not going to be staying in the muscle all the time. It's going to be creating a background that's going to be a problem for you. When we designed our computer program, we wanted to make sure that we removed the background created by potassium, and with sestamibia it's a different problem. So if you process the thallium images using the sestamibia protocol, you're going to be creating artifacts in your image. Does that make sense? So either you're creating an artifact that doesn't exist, so in other words, now your patient has either myocardial ischemia or an infarct that isn't there, versus maybe you may be masking a defect. So the guy does have an infarct or does have ischemia, but because the protocol is being applied in the wrong sequence, now the guy says, hey, you know, Radke, you're perfectly normal. Oh, really? What about this horrible chest pain that I'm having? Oh, it must not be your heart. It's probably something else. You probably got indigestion. Oh, okay. Walk out the door and boom, heart attack and I'm dead. Now, there's actually a question in the medical school that says, you just did a physical exam on your patient. As they're leaving your office, they have a heart attack and they die on the steps outside your building. What do? Huh? No, you make it look like they were walking in. That's the answer.
No way.
I don't know. Does that make sense? You just did a physical exam on a patient, say they're in good health, they sent them out, they died outside, you make it look like they were walking in. Okay. But, okay, so I want you to understand a little bit about these filters because very, very important. If you put too much filter on, you create defects. Okay? This is what they're basically trying to tell you in this section here. We don't normally use cutoffs of more than 25%. So like I said, any pixel that's 25% higher than the average is going to be removed. Okay? This thing up here is what they call the order, or the slope. So in other words, what this means is that in this case here, the filter is being applied at a much faster, at much lower count rates than this one down here. So this one has what they call a higher order, which means you're allowing more background before you start the filtering process. Okay, they both have the same cutoff, but this one has a different order compared to this one. See the difference in the slope? So in other words, I'm allowing more background and stuff like that, then all of a sudden now I'm going to start applying the filter and cut that stuff off. Over here, I'm applying the filter pretty quickly, so it's removing stuff pretty fast from the image. Okay? But like I said, here's the thing, if you apply too much of a high filter, in other words, too high of a cutoff, you're going to create artifacts. You're going to have patients with photopenic areas. You're going to have hearts with ischemic or infarcted areas that don't exist. Over here with a low-pass filter, okay, remember you're smoothing the image, and typically we use a 9-point smooth. Okay? If I'm using a 5-point, now, the reason we have these different options is because of time constraints. Going through 4,096 pixels, doing a 9-point smooth takes more time than just looking at 5 or 3 pixels. So if I'm doing a 5-point smooth, then basically it's going to be 1, 2, 3, 4, and 5. Okay? 3-point means I'm just looking at 1, 2, 3, just like either in the X or the Y direction. Okay? This one would take the least amount of time, this one would take the next most amount of time, this one takes the longest. Okay? So, one of the other things that we do is after we acquire the image, have any of you ever seen what a 64 by 64 matrix looks like? I mean, let me see if I think there's a good picture of it here.